Welcome to the Asking Why podcast. I'm your host, Clint Davis. And today we have a special guest. And this was a recommendation from several of our listeners and a couple of my friends. So shout out to Sam because we've been talking about him for a while. So Chris Leins, he's an LPCC. He's also a veteran. We were talking a little bit about how we were deployed around the same time to different places, which I thought was really cool. And the reason that, I'm thankful for having you on, Chris. The reason we're having Chris on is that he is really an expert in OCD and anxiety disorders. He runs the how do you say it?
Kentuckiana.
Yeah, Kentuckiana Treatment Center for Anxiety and OCD. So, man, I'm here to learn from you, to hear what you're doing, to kind of hear the current state of people struggling with this stuff. But welcome, man.
Thank you. Appreciate you having me, man.
Yeah, absolutely. So tell us kind of how you got into being a counselor. I mean, you're a veteran. Why did OCD and anxiety become kind of the way that you've gone? Just tell us your story and leading into that.
Yeah, it's interesting. I'm not sure how much of a real answer it is. It sounds kind of corny, and it does a little bit on the cheesy side, but I don't like to say that I chose anxiety disorders and OCD. It really feels in some way like God in his sovereignty or OCD chose me. It just kind of the way things happened. I needed a job. I was moving from the East Coast to Louisville, Kentucky. And
yeah, what a beautiful part of the country, man.
Yeah. And needed a job. And so I threw out some CVs, some resumes, and was able to get an interview and scored what turned out to be really a career-making opportunity. But at the time, I truly didn't know that I was applying for an OCD job. Even through the course of the interview, honestly, I didn't put two and two together. It wasn't until actually I'd started the job, I'd made the move, and I was living in Louisville. I'd started the job, and I was what's called a Confederate on an exposure, really meaning something of an exposure facilitator, or you might say it more simply like an actor in an exposure to make the exposure for the patient feel more real.
Mm-hmm.
And it was really then or around then that I realized, okay, this is a specialty kind of clinic. This is an anxiety disorders and OCD job. And I didn't know, even despite graduate school, I didn't know much about OCD or, really how to treat it.
Yeah.
Or
you can say that about everything with graduate school, right?
Yeah, it seems that way, at least with regard to clinical counseling. I mean, I think you get some information, but it's kind of like a Walmart. I mean, you get like a wide breadth of stuff, but you don't really get anything very, very deeply. So you're not an expert in anything, despite having a graduate degree and helping people. Anyways, so that's how really I got into it. The first month in was drinking from a fire hose, very, very difficult in terms of understanding what was going on and how I was going to function effectively as an OCD therapist, or if in fact even I was going to stick with it. So that went through, and over the course of time, I began to feel a deep personal passion for what I was doing, and was really thankful for the opportunity I'd received. I could say a lot more about it, but the long and the short of it is, I don't know that I really chose this. It just kind of happened the way it happened. And I discovered that not only am I something of an OCD or myself, I have anxiety too, but I love doing the work.
Yeah, man. Did you know, because I struggle with OCD and anxiety as well, a lot from, I thought a lot from like deployments and being in gross situations and just that triggering things. But then as I've kind of clinically looked at it and worked through therapy, it's like, man, I've been doing some of this stuff since, childhood and some trauma that was early on. I think that's kind of the typical thing that people find is like they're dealing with the thing that's right in front of their face. And then they realize, oh, these things actually have been going on for quite some time. So what, when you got into working with it, had you gone to therapy for that before, or was it kind of simultaneously you're realizing, oh, I have some of these things? Like, what was the story there?
Yeah, so like I had emetophobia for a long time, and emetophobia being the fear of vomiting. I had that for a long, long time, and for many years, back to when I was, I don't know, man, probably 6 and 7 years old. I would feel almost panicked, even though I didn't have any objective signs of having a stomach flu. I would get really panicked about I'm going to throw up, and kind of made a bit of a fool of myself on a number of occasions. But back then, this was back in the like late 80s, early 90s, there just wasn't a lot of information out at the time on emetophobia, obsessive compulsive disorder, clinical anxiety. And what we were doing anyway at the time was something more akin to cognitive therapy, which at the time was relatively new itself. So I don't know that like you're saying, I put a whole lot of this stuff together until I was actually something of a practitioner in the field, and I realized not just OCD tends to present in a lot of different ways, like myriad ways, a high variety of symptom presentation for people across subtypes and so on. But I also realized, like, okay, I actually have this too. I can totally relate to
Yeah.
intrusive fears that, my wife is going to cheat on me, or that she's not really actually all that interested in me. She just sort of found herself in this position where we're together, and I guess she's going to stick with it, but she's not really into me. And I'm totally, like, totally into her. And so that sucks the way that works out. And so a lot of intrusive thoughts like this
Yeah.
happened for me. And again, just sort of beginning to put the pieces together and realize, yeah, that this is, and like you're saying, that's the case for lots of people. They'll
Yes.
realize once they have the sort of epiphany, I have OCD, they realize, okay, I've actually been dealing with this for many, many years, unbeknownst to me.
Mhm. I had a client this week. I don't know about you, but I love right now with OCD. Like I'm not a specialist, but I've been really trying to learn more and work with it more because there's so many few people to work with it in our area. I have 27 clinicians in my clinic, and only a couple of them even want to deal with it or have any training. And so, but it's become more and more common. I don't know if it's actually more common or it's an exacerbated like diagnosis or if we just didn't know enough about it or some, in between, which is probably the case. But I love just to put people on you. Like, I love your podcast. I think people should, OCD Straight Talk podcast. If you want to listen to more of Chris, you guys should go and listen to it. It's quick. There's, anywhere from 12 to 20 to 30-minute clips, real stories, practical, really helpful clinical stuff. So we're not going to cover it all today, but you can go listen to that and I think it'd be something that would really be worth your while. So as you've been working with it and intensely working with it, what do you think the best, kind of modalities right now are for treating OCD?
Yeah, good question. So if I could circle back for just a second in terms of
Sure.
resources, another resource that actually just came out a couple of weeks ago is OCDspace.com.
Okay.
OCDspace.com houses Oscar, the world's first clinically trained AI OCD coach.
What?
In some real way, I don't want to use the nomenclature of chat GPT because then people think, oh, it's just another chat GPT. It's not another chat. Oscar, however, is like this in a sense that you can interact with Oscar in real time and his interactions with you are personalized. And they're specific to what you're saying to him and what's happening for you. And this quote unquote advice that he's giving is evidence based. It's rooted in the literature. It's focused on the evidence based protocol. He works at helping users identify their compulsions. He equips them with tools that, like I say, are ERP focused. Back to the question that you asked a moment ago, exposure and response prevention is the gold standard evidence based protocol for the treatment of OCD. In any case, Oscar, like many OCD specialists, is trained in ERP. And so he can supplement what's happening for patients. That is to say, he can supplement the work that patients are doing with their therapists. He's also capable of helping to facilitate progress on his own for users who maybe are living in parts of the world where there isn't a lot of specialty resource. So anyway, just quick plug for OCDspace.com. But in terms of your question, ERP or exposure and response prevention really is the gold standard. There are other modalities that are available and that are proven to be effective. Of course, among these are psychotropic medications to include SSRIs or selective serotonin reuptake inhibitors. But there's also other behavioral or cognitive treatments like cognitive therapy or cognitive behavior therapy. Really, ERP is something of a grandchild, you could say, of CBT or cognitive behavior therapy, and it's
Right.
specific to the treatment of OCD.
Yeah. So you were saying that earlier that you were playing a role in kind of an ERP session or in exposure therapy. So can you talk a little bit about that, what that would look like for people and why that's helpful?
Yeah, you mean the role or do you mean exposure work?
Well, both. I mean, just kind of what are the ways in which, you break down kind of how that looks for people and you were playing the role, but like most people don't even know what that means. So
Yeah, yeah,
can you
that
give a
totally
general
makes sense.
overview of it?
Yeah, yeah. So the role, like I say, I was serving as what's called a confederate, and that language can feel confusing for relatively obvious reasons. So if we can kind of get away from the language, really, again, it's something of a exposure facilitator is more technical wording, or we could say I was an actor. I was pretending to be something that I wasn't to facilitate anxiety production for another person. So this particular exposure was relative to a person who was dealing with what's called SO, OCD, or sexual orientation OCD. Back in the day when I started doing the work, it was called HOCD. H stood for homosexual. So the fear for these individuals, by way of often intrusive images, is that their sexuality either is changing or that it already has changed, and at this point in their lives they've been sort of fooling themselves as either heterosexual or homosexual, and the point again being that their sexuality is changing, and the evidence that that's happening for them is the intrusive images that they're experiencing. So for
Mhm.
this guy, like I say, he was dealing with SOOCD, and so the exposure was to go on a date with a guy. And
Mm.
so I was the guy, and lucky me, I'm fresh to Louisville. I don't know anybody except for my date, I guess. And I didn't really know OCD work either. So I really have no idea what I'm doing. And like I say, this is something of the introduction to the work and the looming question of whether I even want to stick with this. Here I am dating a dude, and I don't know how I feel about all this. But in any case, but it would have been helpful for him in the sense that no doubt at all during this exposure session, and I can break that term down
Yeah,
more
please.
if that's helpful, he would have been experiencing intrusive thoughts about sex with me or about whatever. And of course, totally analyzing and worrying, what do these thoughts mean? Why am I having them? His anxiety would have been screaming high in all reality. But by that point, he would have been working to stop his compulsions. And that's really the active ingredient in the exposure process. So
Mhm.
exposure is just really meaning I'm engaging in activity or a situation. And that those terms can be applied very broadly. Sometimes it's like looking at a picture
Mhm.
that's anxiety producing, or like I say, engaging some activity or going to a certain place that elicits or activates intrusive thoughts, images, or urges.
Yeah, it could be putting dirt on your hands or getting
Sure.
liquid on your hands or,
Yeah, good call.
leaving the light on or whatever the thing is that's setting you off.
Yeah, that's it. Whatever's setting you off, that's the idea. And then we're working to, again, active ingredient resisting the compulsions is resisting the compulsions. For a lot of people, though, those compulsions they're insidious, they're subtle. They're engaging compulsions. Most OCDers are engaging compulsions that they don't realize are compulsions. They think that these are idiosyncrasies for them or these are harmless behaviors, but in fact, they're part of the OCD, and they don't realize that. So that's a big question, not just,
Yeah.
can I stop my
What are some
compulsions, but what
examples
are
of
they?
that?
Yeah, so like you have your stereotypic compulsions like hand washing, ruminating, seeking reassurance, avoidance, all these kinds of things, and many, many others that are stereotypic, that are cookie cutter and relatively obvious, time consuming, unhelpful, or maladaptive behaviors. But then there's something else that I like to call micro compulsions. And it's not in the literature of the term very much. John Abramowitz did coin the term. I think he used the term micro rituals, use a variation of it, micro compulsions. But the idea of a micro compulsion or a micro ritual is something like bouncing your legs or gritting your teeth, clenching your jaw, or maybe picking the skin around your fingernails, biting the skin inside of your mouth. Many, many behaviors like this that they meet the definition of compulsion provided by the American Psychiatric Association, but they definitely don't fit the general public's idea of what a compulsion is. And so therefore, OCDers, though they may meet diagnostic criteria for the disorder, they don't see these behaviors as compulsive, and therefore they don't work to resist them, and therefore they don't make much progress.
Got it. Yeah, that makes a lot of sense. So you got the guy, you're going on the dude date. He's anxious. He's having intrusive thoughts. He's not wanting to, to obsess about those things. So what are the things that he's actively doing to stop that compulsion?
So hopefully, I think what I'm hearing you ask is because compulsions are behaviors. So the answer is in the question: what is he doing to stop the compulsion? Stop the compulsion, right?
Yeah,
The
yeah.
question is, what are the compulsions that he's doing? Are you asking me what are the things that he's doing to try and stop the intrusive thoughts? Or are
Yes,
you
sorry. Yes.
okay? That's okay. That's okay. So yeah, I mean, in all likelihood, for him, it would have been I don't remember, but it would have been like not looking at me. It would have been a lot of like looking down, trying to keep the intrusive thoughts from showing up. He would have been reassuring himself in his head, "Oh, these thoughts don't mean anything." It might have been something like this. It might have been potentially bringing it up in conversation again. I don't have any recollection of what we talked about, but
Yeah,
it
it's
could have been
okay.
like seeking reassurance from me. Like I say, avoiding eye contact, reassuring himself. Thought blocking would have been a very common one for someone with SOOCD, just like trying to force the thoughts out of his mind.
Yeah, and those are the things we don't want them to do, right? Like those are the things that they're doing just for the audience. Like those are things that everybody kind of does to try to, keep the obsession from happening and the intrusive thoughts from coming in. But
That's it.
what is it that we teach from a healthy perspective that people can do instead of all those things that don't work and just keep the rumination and the, obsession going?
Well, that's really where the real work begins, right? So in my clinic at Kentuckiana Treatment Center for Anxiety and OCD, I teach the art of exposure therapy as an acronym. So the
Okay.
art meaning acceptance of uncertainty. That's the A in art. Resistance of compulsions. That's obviously the R. And then tolerance of distress. That's something of a sequential map that we can follow through again and again and again, because, of course, intrusive thoughts happen repeatedly in real time for us as we're engaging
Hmm.
situations and activities. So it's like we can work to resist uncertainty, and we should. That's really where ritual prevention begins, I would argue. Yeah, I don't really know what this thought means. I don't know why I'm having it. I can ruminate on that. I can analyze it. I can ask somebody else what they think, but I'm still not going to know really why I'm having these thoughts or what they mean. So really the best thing to do is for me to resist the compulsion. That is to say, asking somebody else or ruminating, because no matter what I do, I'm still not going to know what
Hmm.
these thoughts mean or what the future holds. So I'll resist the compulsions again. That sort of pings the question of, well, what compulsions am I doing?
Hmm.
And from there, when I'm resisting the compulsions, I'm tolerating the distress. And this is the hard part. Right? Not
Hmm.
that the other pieces are easy necessarily, but the prolonged and repetitive, and those words are very important, work of tolerating the experience, the presence of intrusive thoughts and the anxiety that they cause. That's
Hmm.
really how the intensity of the intrusive thoughts, the frequency of the intrusive thoughts begins to fall, much like you get into a swimming pool that's cold in May or early June, and you just sort of hang out in the cold water. And over time, it gets less uncomfortable. This is very much the same idea, or working to not scratch a mosquito bite. Eventually, over time, the itch starts to go away on its own. This is
Hmm.
very much an illustrative and educational picture of what it is to manage OCD effectively.
That's great, man. I love that ART acronym because that's very, very helpful. And some of those are, I mean, definitely the things that have helped me. And I think so much of that is, that tolerance piece is hard. But without the other two pieces, if you're just kind of trying to grin and bear it and white knuckle it, then it ends up just becoming rumination or, obsessing or, being compulsive or whatever. But if you can walk through those two things, acknowledging it, resisting it, and then tolerating it, is that right? The same, right? Yeah, okay. Yeah, I mean, the tolerance is much easier when you've done the acknowledging and the resisting.
Yeah, well, I think that's true to a certain degree. I think
Sure.
that yeah,
Not
tolerance.
easy, but
Sure, right, and I think that that's something I often say to patients is it's simple, but it's not easy.
yeah,
Because
no.
it again, at the end of the day, compulsions are choices, and oftentimes, man, I've heard it so many times that people will say, "I can't stop my compulsions," and, with respect to everyone listening, I would say, "Bullshit. You can stop them, you just don't." And I'm not wagging a finger, I'm not in any way being critical, truly I'm not. I'm meaning, in fact, to be empowering when I say, "You can stop your compulsions, you're just not stopping them because you're very anxious, because you're experiencing intrusive thoughts, and you think the only way out of this is to do the compulsions." That's not reality. Actually, the best way to get out of the cycle of the system is to manage and work to resist the compulsions, is to identify them as the problem, actually. The compulsions are the problem.
Mm,
And if we can just
yeah.
tolerate, and again, that's the hard work, tolerate the experience of the intrusive thoughts, and again, the distress that those thoughts cause, that's hard work. This is where it's complicated, it's difficult. Again, simple to stop compulsions, but not easy, because on the other side of that is this distress that I'm just tolerating in the meantime, like this gentleman was as I was a Confederate or an actor in his gay date. That was a really hard, no doubt for him. But probably if he was working to resist compulsions by the end of the date, 40, or whatever, 60 excruciating minutes later for both of us, his anxiety probably was significantly lower than it was in anticipation of the date or when we first sat down. And, I'm a
Yeah,
sexy guy. So, it can be, super, super anxiety producing, I would
I
imagine,
bet.
for someone with these kinds of intrusive thoughts. You know what I'm saying?
That's right. Yeah, man, Gay Date, that's a great new podcast that we can start together.
Very nice.
That's great. Yeah, man. No, that's perfect. I think that's very wise and good and encouraging because I mean the same thing with like I was telling somebody about triggered. We just live in this culture right now where to give somebody a diagnosis like OCD is so helpful because it's like, yeah, you actually have a clinical thing going on. You're not just choosing these things, but then you get into the work and it's like, but you are choosing some things. And it's the same thing with like trauma. It's like if you're on this lopsided view of it, it's like, well, you have trauma, and so she's triggered or he's triggered, and they can't help it. And a lot of times I'm like, well, you were triggered, but now we've done the work and now you're being reactive. You're not just triggered and out of control. You know what's upsetting you and disturbing you, and yet you're still reacting to that as if you didn't know. And so I think that's a great point to call BS on people saying, "Well, no, I just cannot help it." It's hard, it's difficult, but you're not helpless. And I do think that's empowering.
Yeah, absolutely. I think you're right. And I think that that's the right word. It's empowering because it doesn't wag a finger, but it does create some clarity in terms of where the exit door is. We
Mhm.
have you're familiar with the term azimuth, of course, as a fellow and a former soldier. I mean, the idea is I'm pointing my compass at something specific and I'm shooting an azimuth. Now I have a very
Mhm.
specific direction that I'm following. It's precise and I'm working hard to continue in that direction. Now I'm not so much lost, right? I'm orienting the map, I'm following the azimuth, and I'm navigating the land. Well, helping individuals that are suffering from clinical anxiety to identify where they have control and power. They're shooting an azimuth, right? You're
Yeah.
giving them control and power. You're giving them something to work on that's proven to facilitate results and to reduce the intensity of their anxiety.
That's great. Yeah. From a Christian perspective, it says, scripture says, without vision, our people perish. And I think it's the same idea that if you're just tolerating suffering and pain and intrusive thoughts and you think there's no hope and you're just white knuckling it and this is never going to end, that's difficult. That's impossible. But if okay, I'm working with somebody, they've helped me, they're carrying my burden with me, they're counseling me and teaching me, and this actually is the best way to do it, then you're right. You can make that empowered choice of like, I don't feel like it's the best way to do it. I want to go back to doing the thing I've been doing for 30 years that temporarily fixes the problem and just makes it worse. Man, if I can acknowledge like this is part of it, I have OCD. These are where it's coming from, and was our resist making doing the thing, picking your finger, locking the door, turning the light off. Yeah, then I can sit and go, okay, and this is just what it is. Like it just sucks and it's part of it, and I'm gonna be in it for a little bit, but that's gonna make it better.
Yeah. But I think at the same time, going back to what you said about like, I'm falling back to the thing that I've done for 30 years. I think that the truth of it is that makes sense. That's what we know. What we know is the rumination, or what we know is the avoidance or the checking or seeking reassurance, again, whatever it is. And so I think oftentimes I'll say to patients, just sort of like gearing up that this is going to be hard. Like, this is not going to be, you're not laying down on Freud's couch and we're just going to spend the next 2.5 years, 4 days a week with free association and talking through what happened with your mom and whatever. This is going to be hard work. It's very active, right? It's structured. And my commitment is to help you to get some results. At the end of
Mhm.
the day, that's you've hired me for results and I'm going to help you with that. But this is going to be hard. So when we lock in, let's go to war, right? When you show
Yeah.
up to session, we're here to fight the OCD. And so I want you to come with your game face on. Be ready to identify and resist compulsions. Be ready to practice the skills, knowing this is going to be hard. And if we enter this process with that mindset, we're probably going to be more likely to be successful than if we think, oh, this is going to be easy and it won't be all that hard and all this. You're going to be in for a rude awakening.
Yeah, what therapy is supposed to make me feel better, Chris. Like, what are you talking about? It's like just such a I lay on the couch and I leave feeling validated and good. So yeah, I mean, I'm with you. We're especially doing that work. I'm sure you feel the resistance of pushing back against kind of the cultural psychology of today, and in this particular. I mean, I think a lot of things also need that same level of accountability and work. I think most people don't want to pay $200 to come and sit and just talk, but especially in this particular modality with OCD and anxiety, yeah, we need people to help us.
Yeah, man. I mean, I cut my teeth as an OCD therapist working at the Louisville OCD clinic. And I think actually now this is the case again, but for a period of time it wasn't. At the time, they didn't take any insurance. So it was like I don't remember what they were charging, but it was a fair amount of money. If I'm not misremembering, it's more money than I charge now, 10 years later, with a decade of experience, having treated like 900 people for OCD. I still don't charge that. But the point is, people expected results because they were paying handsomely for services. So there was pressure, like it or not, to help people achieve real, measurable, predictable results. And like you're saying, that's a fair expectation, right? I'm going to see a therapist. This person's licensed, this person's trained. He or she should be helping me get some results here. And it shouldn't take, no shot at Dr. Freud, but it shouldn't take 2.5 years, 4 days a week to get some real progress and relief.
That's right. That's right, man. Yeah, same thing. I love marriage therapy. It's kind of the thing I do the most of, and it's like, yeah, I want to see you in the next 3 to 6 months being happy again, being connected again. I don't want to be here in 4 years and you guys are still hashing out like what you did to each other 15 years ago. That's great, man. Any, f- if you got an audience, I know you got your own podcast, you say stuff on, but to my audience, is there any like particular thing that you're like, man, I really want people to know this about anxiety and OCD, and I think it's a helpful thing that most people aren't talking about?
Well, I think that most people, meaning most licensed clinicians,
Yeah,
meaning
and
most,
podcasters and whoever else that are
yeah.
just missing it.
Well, I think that the active ingredient of the treatment process is ritual prevention. And we could probably honestly do a whole conversation just on the idea of behavior change and what behavior change has the capacity to do in terms of changing the intensity of thoughts for people, really regardless of what those thoughts might be and the emotions that those
Hmm.
thoughts elicit. Oftentimes, simply by changing the behaviors that we're using to reinforce our thoughts and feelings, we end up having a pretty significant effect on our thoughts and feelings.
Hmm.
Again, just by working to change the behaviors. So I think that I would say, and going back really to 1966 with the dawn of exposure and response prevention with Victor Meyer and his groundbreaking study, the active ingredient here is behavior change, is ritual prevention. So if we're
Hmm.
working hard, no exceptions, no excuses, no shortcuts, but we're being serious, we're working diligently, we're being disciplined, again, rolling up our sleeves and working hard to identify and stop compulsions. That's something that everybody everywhere can talk about. And most people honestly have at least some awareness of the compulsions that they're doing. If they're paying any attention at all, most people have at least a few behaviors that they can recognize that, this is probably one of those things that Chris was talking about that I can maybe not do. And it's going to suck for me if I don't do it. It's going to make me feel really uncomfortable and anxious if I don't do it. I would say, okay, that's probably one of those behaviors. Let's work to resist it. And
Yeah.
again, tolerate the distress on the other side. And let's just see what we can get done in terms of results.
Yeah, that's good, man. It's a little bit the fake it till you make it kind of thing. It's like people want to feel good about whatever the thing is that's going to make them, change. But it is true. Like what you practice tells your mind and your body what you believe. And so there is this, I was telling a couple of weeks ago, they were talking about, we love each other. And I was like, well, what do you do to show each other you love each other? Well, not much, right? And it's like, well, okay, we'll go home and hug each other and say you love each other every day. And if you don't, like, there's no point in coming back because you don't love each other. It's
Hmm.
like I can't help you literally if you don't love each other. So are you will, you can tell me intellectually that you ascend to the idea that you love each other, but if you're not going to practice anything in your marriage this week that shows the other person you love each other, what are we doing?
Yeah, I think it's a fair point, man. I mean, I'll often say to in supervision or to patients or on the podcast, I'll often say it's like if you don't want to get better, if you don't have the intent, the commitment, if you're not ready to put forth the effort to get better, I mean, there's really nothing I'm going to be able to do, honestly, that's going to help you get better because at the end of the day, you're responsible for the choices that you're making, and I can't control those. So again, the active ingredient is resist compulsions. You alone control that. So if you're not interested in getting better, nothing I'm going to do or be able to do. But back to what you were saying about what was that? Forgive me. Fake it till you make it. I
Mm,
think there is some real truth. I hate that statement, but there's some real truth
I
to it.
know, right?
Right? Yeah, I mean there is. There's another phrase that it's easier to act yourself into a new way of thinking than it is to think yourself into a new way of acting. And
Hmm.
again, it focuses on the power of behavior change and what behavior change can do in terms of making it, in terms of how I actually do feel and the things I actually do believe and think in the same old situations. And activities that I've been engaging. It's, I'm faking it until I'm making it. I'm literally acting like I'm not anxious, and I'm ignoring the presence of my intrusive thoughts. I'm not blocking them out. I'm not reassuring myself and ruminating in every sense, mentally and behaviorally, ignoring my intrusive thoughts. And then I'm thereby resisting my compulsions. Again, that's another way to say the same thing.
Yep.
I'm ignoring the thoughts.
It's
Therefore,
great.
I'm not doing the behaviors. I'm just tolerating. Yeah, I mean, that's streamlining the process. You're going to make progress.
So good, dude. I mean, that's so incredibly helpful to people, especially in this specific issue and struggle with anxiety, compulsion, and OCD. I think my encouragement to people would be it is helpful to be validated. It is extremely helpful to know you have OCD. It's extremely helpful to know that you're not the only person with those thoughts, and that, those thoughts are really scary. Those intrusive thoughts are really scary to tell someone you're having, especially, work with people who have, they're afraid they're going to abuse their child, or they're afraid they're going to all of a sudden, become a pedophile, or they're going to murder somebody that they have done that. And they don't remember it, all the things that people struggle with. And, coming into our offices and finally being honest about that and saying, hey, this is what I'm thinking, and they've never told anybody else, man, that's so important and valuable. So I know you're not bypassing that. So can you speak a little bit to that part, and then how you transition people from that kind of, that safety net of, oh man, I'm not alone, I have this diagnosis, to the actual hard work?
Yeah, so like that's a great question. So let's continue with the example of harm OCD. That is to say, the intrusive thoughts that I'm going to hurt somebody, whether on purpose or by accident, whether with my car or with a knife or whatever it might be. Oftentimes, you're right. Patients will come in and they'll say, this is not something I'm talking about. And a part of the reason, honestly, that they're not talking about it is because they have talked about it before, in at least some cases, and they've been totally
It went bad.
misunderstood. Right,
Yeah.
by a therapist, by the way. I mean, I've talked with many, many people through the years with various kinds of taboo fears, and it's been like, they almost call the cops on me. Like,
I know, man. It's crazy.
right. So I think that normalizing the intrusive thoughts is maybe the language that I would use relative to, how am I demonstrating empathy, or helping people to unpack what's happening for them? How am I bearing witness to it? That's pretty short-lived, if I'm honest, because it's true that people do want to feel understood. But in my experience with OCDers, more than that, they could kind of give a rat's ass if they're understood or not. They want results. They want to
That's
feel
right.
better. Make
Yeah,
this
you got
stop.
like one session where you go, okay, this is what it is. Now let's do the
Yeah.
work. Yeah.
Yeah, exactly right. That's precisely right. And so I'll say, I'm going to say this one time, and then I want to be able to move on from it. And this is the one thing I'll say to you is, you're experiencing OCD, okay? And this is what's called harm OCD, or what's called POCD, or whatever. And many, many people around the world deal with what's happening for you. I'm really sorry to hear what's happening for you. This has, must have been debilitating and awful and all this stuff, blah, blah. But then I'm going to clarify, we're not going to do this again. Okay. And the reason that we're not going to do this again is because I want to help you. I want to help you. And this idea of going back and forth, is this normal? Is that normal? Well, can you tell me that my thoughts don't mean anything? What about this? Am I okay? Is my kid in danger? Am I a bad person? It's like, listen, you've tried this. You've done
Yep.
this for
That's
years.
the ruminating. Yep.
Yeah, you've tried with ChatGPT, and you've tried with your wife, and you've tried. It doesn't work. And I'm not a magician. It's not going to come in here and so all of a sudden it's going to work. It doesn't work because it doesn't work. So let's not do that. What do we have to lose by trying something else? So let's do this work of accepting uncertainty, resisting compulsions, tolerating distress. And that's a process, and it's hard, but there's 60 years literally of outcome data that supports that route. And there's no data that says, well, if we talk about it long enough, it's just going to fall apart and go away. Let's not
That's
do
so
that.
good. That's so good, man. That's so encouraging. I think people need to hear it. That's why I wanted to have you on, man. I know you're a straight shooter, and I love your work, and you do. You have the proof is in the pudding. You've helped a ton of people. People I know, you've worked with people, help people through your podcast. I mean, people just listening to this and hearing this, it's encouraging, especially for people who, like you said, they want it to stop. Like most people they want some validation for a second to know they're not crazy. And then they're like, all right, let's get on with it. So I'm proud of the work you're doing, man, as a fellow veteran and somebody who's been through a lot. It's really cool to see, all that you're doing, how you've grown, and where you come from professionally, from, the reserves to now. It's a very similar story in different ways to me. And that's just rare. it's really rare for me to run into somebody who kind of made it out of the military and became a therapist and is doing the same kind of work. And so I think it's really, really cool. And I'm encouraged by you, man, and what you do.
Thanks, man. I'm honored. Really, it's been a privilege for me to be on your show, on your podcast. And my passion, brother, my passion is to sort of, as Paul said to Timothy, to kind of do my ministry. I hope that I'm not taking his words out of context or misrepresenting the scripture there. But I think among many others too. But it's a ministry that God has given to me, again among others, to help people with OCD, with clinical anxiety that are, I mean, they're lost. There's just so much bad information out there. They don't really know what to do. And the rumor mill, it just constantly churning out bad advice that people are gobbling up and taking, and they're not making progress. And again, they're discouraged, they're hopeless, they're lost. So thank you, brother.
Well,
Thanks for having
yeah,
me on.
man. Well, I'm gonna you touched on it there for a minute that we could kind of talk about that for a whole nother podcast. So let's do that. I want to, have you back on in another month or so, if you got time in the next quarter or year or something, and just talk deep dive on some of the practical ways in which we work through those things, and I think that'd be helpful to folks.
I'd be honored, man.
Cool, man. Well, thank you so much for your time, guys. If you want to look Chris up, you can find him at what are you got a podcast going? So Straight Talk Podcast, right? That's the name. OCD Straight Talk.
Yeah. Podcast is OCD Straight Talk. You can find it wherever you get your podcasts. My website, the Kentuckiana Treatment Center for Anxiety and OCD practice. The website is KentuckyOCD.com. I would again plug OCDspace.com for Oscar.
I'm gonna check that out.
Yeah, man. Yeah, world's first clinically trained AI OCD coach, and then of course.
That's it. All right, man. Well, I appreciate you sharing it. And guys, if you need some help, reach out to Chris. Thank you, and God bless you. Have a good week.